to order. Uh, Please note for the record that Dr. Tony Aisaline is representing Dr. Michelle Morse, and Dr. Ted Long is representing Dr. Mitchell Katz, both in a voting capacity. Thank you. So I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on June 16th, 2025. All in favor, please say yes.
Yes.
Opposed, say no. So the motion carries. So next we will hear from Ms. Brown as they provide an update on the system dashboard.
Yes. Hi, everyone. Good morning. I hope you're keeping warm. We're going to start, as we usually do, talking about the external affairs overview to give you sort of a context for our strategic planning dashboard metrics, and then go into the dashboard itself. If you want to get on the next slide. So not surprising, there's a fair amount of, I should say, chaos, swirl, indecision, things like that on the federal level. We're still engaged in a good amount of advocacy on components of HR 1, particularly delaying elements of it, the MCO tax, the impact on the essential plan. My colleague and team member, Ali Noodleman, is actually in DC as we speak, doing Hill visits. We've been down there a lot. But we are, continuing to focus on that, as well as administrative actions that are coming from this administration in a non-legislative way. On the state level, we're at that sort of inflection period where the end of last year's session is kind of coming to a close. There are still bills, including bills that are of interest to us in the health system, that have not yet been delivered to the governor. That needs to happen by the end of the year. However, we are starting really in earnest on advocacy, on partnerships for this coming legislative and budget session. We've begun our meetings, by several months at this point. And it's an interesting year just because there will be a lot of, I think, connection between the federal and the state. Essentially, a lot of the state budget is going to be about figuring out how the state might take actions to plug holes from HR 1 on the federal level. And, kudos to the state that has been really great partners throughout. And then city, not surprisingly, again, another transition period. We are very excited. The mayor-elect coming, we have great hopes and expectations. His values are our values. We're really excited to see some of our old friends coming back from prior administrations. So, there's always a certain amount of up and down just getting to know new systems, but we are very, very positive and looking to go full steam ahead. All right. In terms of the dashboard, we're going to talk about it as we usually do, first talking about the positive, then the sort of close to positive or, yellow lights, and then a couple that are negatives, right? And so starting on the positive side in terms of our, we'll start on quality and outcomes, the HbA1c control, that continues to go up. This is an improvement from last quarter and from quarters before. My colleague, Dr. Long, is here, so kudos to him and to his team. And then for the next one as well, unique primary care patients. This is really an exciting one too. We continue to grow. Our target there is 450,000, and we are well eclipsing that at this point. And this is something you've heard Dr. Katz say in the past. We are a primary care system. We are very, very proud to be. We're also very proud of the fact that people came for COVID and essentially didn't leave. And, this is, again, kudos to Dr. Long, to his team, all of our primary care providers.
Can I ask a question?
Of course.
Particularly since Dr. Long is here.
Yes, I was going to say.
Yeah.
The ambulatory guy. Yes.
No, I mean, this is really great. Right? This is what we've been talking about, and that target needs to go up now, right?
It will, don't worry.
Yeah. I have no doubt. But what about on the provider side? How are we doing in terms of, this is great growth, and I know it's hard to find primary care physicians. And how's that going? What do you see for our growth in that area?
Yeah, so just to contextualize this number of 462,000 here, and I promise I'll stay on my soapbox only for a second. This is a really big deal. 8 years ago, we were losing patients every year. We've reversed the trend, and this is the most patients in the recorded history of our health system.
Pause.
Yeah. And people are coming to us more and more every day because they trust us and they have family members that trust us. So what we're doing to keep up with the really positive demand that we're seeing is not only are we trying to recruit the right primary care providers that we need, but also understanding that there is a national shortage. There isn't enough primary care doctors in the whole country. For any part of the country, let alone New York City, as we're trying to think also creatively about how we can expand our care teams. And that's, I think, where a lot of the money is for this coming year. For example, 8 years ago, it used to be that when I was in Morrisania, I would titrate my patients' insulin. I'd have them come back every week, go up by a couple units, try to get their A1C under control. Now, I refer to my treat to target nurses and my clinical pharmacists. We had 0 clinical pharmacists when I started 8 years ago. But that translates into visits that otherwise I would be taking as a primary care provider that now I can take. If it's 5 visits to titrate insulin, that's 5 new patients I can instead see. So things like that make a really big difference in us being able to keep up with the number of New Yorkers that are coming to us that we anticipate will only go up with a lot of the other things that Deb is talking about here now. So in summary there, we're focusing on retention, we're focusing on recruitment, we've increased our primary care salaries. I'm doing a town hall with every single site, which I'll actually conclude this month, hearing about what's important to them, and we're implementing a series of changes across primary care to make their lives better. Like bringing ambient listening in, things like that. But also expanding the care teams is really crucial to be able to keep up, understanding there's not enough primary care doctors to begin with.
That's great. Thank you.
You're welcome.
And I knew you had a plan.
Good? All right, next one. Our care experience numbers, again, really admirable, continuing to go up. Our MyChart activation, I do want to pause on this, 87.6%. Our target was 84%. That continues to be well above the national average, which I believe is 54%. And we're seeing that. What I love about this one too is sort of the creativity about it. We're getting people through text messages. Certainly, we're getting people through patient emails. But this really allows patients to speak, if you will, directly to their providers on a day-to-day basis. I mean, I use it. I hope all of you use it. It's really wonderful. This is another one. I'm so glad Ted.
Yeah.
The ambulatory care recommended provider office. Basically, would you recommend your provider office? And that number continues to go up. We are very, very close to the target on that, 88.1%. There's lots of great reasons for that. One of it is that we are, nudging people, polling people a little bit more rapidly and sort of comprehensively than we had been before, but that only allows us to reflect the good work. That wouldn't be a substitute for the good work. Next one, sorry, where are we? Oh, financial sustainability, okay. Percentage of uninsured patients enrolled in health insurance coverage or financial assistance, same as the prior period that we talked about, 86%, shooting towards that 90% target. And I know you all know this as well as I do. When people have insurance, that is better for them, that is better for the system, that is better for their providers. It's something we continue to be very committed to, even in light of changes in HR 1 that frankly will make insurance enrollment more difficult. I don't think that's a secret, but it's something I'm working on, our teams are working on with our revenue cycle teams, a lot of really creative thinking in going into how to keep people enrolled as that administrative burden is going to get higher and higher. Total accounts receivable days per month and PAC total account receivable days per month, both of these continue to remember on this one, down is the good thing, right? We want this number to be going down, 27.9 days. That's down from 31.5. And this is one where we revised the target. I think it had previously been 45 days. Taking it down to 30 is sort of industry standard, so it makes it even more meaningful. And similarly, the PAC total days, total AR days, that continues to go down as well.
What is PAC?
Post-acute care. And it's, it's there are their own kind of complications in post-acute care that are a little bit different than acute care.
Can I ask about
Yes.
since we have Jamie? Just targeting people who are here.
I know.
So that's a really good improvement from, and well, 2 questions. One is, what was the revised target for total AR? I mean, what was it before, and why did we revise it? And then
45.
I have a follow-up question, I guess.
Yes, I think we've kept trending it down. I think it was 45 at one point. It may have brought it down to 40, and this obviously is a big jump down to 30. I think, a few things that during, as you probably remember, although Margie would never let us speak of it again, the Change Healthcare outage, this number went way, way up.
Yeah.
And so I think we had that, which sort of was so disruptive. And then beyond that, there were we were trying to clear backlogs of various things that also bounced it up. And then the UPL conversion, sort of claims reprocessing, has also caused blips at times. I think we've sort of felt like we've gotten our arms around all those things. And so, as Deb pointed out, the 30 days is kind of the industry standard. We were close to that the previous quarter. We're below that today. So we think it's a really comfortable place to be. Again, I think there will always be a little volatility in this measure. We're still going to have claims reprocessings and things like that, but that we
And-
feel good.
And yeah, and also I would say there's just a lot of blocking and tackling to this one,
Yeah,
right?
absolutely.
Margie, Allison, that team, they work these claims day in and day out to all of our benefit.
And so, I mean, we clearly have kind of not blown through, but pretty nicely through the targets, the 30 days and the 50 days for post-acute care. Is there some, I'm sorry, I didn't read all the notes below, but is there an anomaly in there, do we think, because of the Change Healthcare backlog and sort of clearing it out or something? Or is this, have we sort of figured out?
No, I mean, I think that these quarters are very strong performance. I mean, I think we'd like to see it continue, but, just the previous quarter, we were above the target slightly. So I think if you kind of average them out, we're right around the target between the two quarters. So I think we felt more comfortable that this was the place to be. But of course, we're going to keep looking at it. And if we can bring it down, in both cases, we will. And Deb, if there's anything.
Yeah, no, that's exactly right.
Thank you.
And then unprint, I think we've talked about this here before. This is our 5-year initiative to decrease printing. I say as I printed out the deck in front of me. And this is something, under Kim Mendez and her team, and it's a really wonderful program, both because it saves us money and because it's better for the environment. Printing, particularly toners, color toner, is something that is really challenging. So we're only about a quarter of the way through it thus far, but not surprising for anyone who knows Kim, we are hitting all of those metrics, and I am sure we'll continue to do so. Okay, culture of safety. We've talked about this one before, so we have kind of two components to this. Our staff is both completing an eye care and kindness pledge, which is sort of a matter of you go in, you read, you kind of click, you make that commitment, and then you go through the training, which is a little bit more laborious. It's, takes a little bit more time. Both of those continue to trend in a positive direction. You can see 57 from 45 for completion of the trend, and then 48 from 37 from the target. I will make a completely unprofessional shout out to my team because I think we're at like 98%. And actually, interestingly, people did the training before they completed the pledge. And so then Jeremy came by and was like, no, you guys have to do the pledge also. And that's something, it's baked into our work in so many ways, but having these specific action steps to take is something Slide. Okay, so these are trends. We're going to be talking about things that are negative but close to target, better than or close to target. So they might be steps down from where we have been, but it is still generally within a very positive realm. Okay, so first one, post-acute care days, all-cause hospitalization. That's when someone who is leaving our post-acute facility has to go into the hospital. You can see the target is 1.6. We've gone up. We had a little bit of blip up to 2.1. As you'll see in the footnote and from talking to the post-acute care team, all of these were determined to be necessary to move people into the hospital. This is care that could not be provided appropriately in the post-acute setting. So there will be, some kind of fluctuations there, but also it's something that Dr. Luong and his team are working on. They are very mindful of it. They've implemented a number of systems, I think, and we expect that will continue to improve. And then the percentage of left without being seen in emergency departments, this is another one I really have to pause on. This has gotten, so much better over the years. So yes, this is a slight increase, 3.5 from 3.4, but you can see we're still below the target. There's going to be some seasonality in this metrics, I think particularly around flu season, RSV, that type of thing. So this remains a very, very good news story. Okay. Inpatient care overall rating, you can see that that dipped down a little bit. And I mean, you can see that is a 0.1 percentage, 65.8 from 65.9. Again, this is one, interestingly, where there is a little bit of seasonality. You know, over the summer, people go on vacation. This is when new residents start. And so those are some reasons, not an excuse, but, you know, when the team looked at this, these are some reasons why perhaps that might explain that little dip. But again, you know, we remain in good shape relative to the target. And then financial sustainability, patient care revenue and expenses. James and I were talking about this one, 76.9 from 78%. It's a little bit, you know, it is down, but it is still higher than the target of 75%. And that's, you know, thanks to James and John and, you know, everybody who works on the finance and the reimbursement side.
Deborah, can I ask a question on the care experience? Do we have any benchmarks from other public health systems, like what their analogous percentage would be?
I don't know the answer to that. I am inclined to say that we are leaders in the space because that is often what we do, but I can come back on that.
That would be
next time.
great, thank you.
Okay. And then these are some negative trends that we're seeing, and you know, as ever, negative trends are going to be addressed. Follow-up appointments kept within 30 days after behavioral health discharge. This one went down 62.8 from 67.1, right? And so, you know, we're around the target, but this is below the target. And this is something the Office of Behavioral Health is working on. You know, everyone is very aware of this. I just want to see if there's anything specific to say there. In a couple places, I think there was some staffing transitions, and Omar and his team are working on those. And then financial sustainability, this is one we've talked about certainly. The percentage of MetroPlus spend at H&H hospitals, this is down a bit again from 38.4 to 38.2, and it does remain below the target of 45%. And yeah, please.
Wouldn't we want to set a relatively higher target for that? Since like MetroPlus is associated with HHC, and our mission is to serve the and underinsured, and MetroPlus is attempting to do that. Wouldn't we want to see a higher target
So
than 50?
100%, but I mean, 100%. No,
Or at least set one. I'm not saying
no,
just
you're
see,
right.
but
And I
set
mean,
one.
as I think you've seen and will continue to see, we do shift the targets up or down appropriately. We want to keep challenging ourselves. I promise you, if we get to 45%, we're not going to stop there.
Right.
But no, it's an important thing to keep an eye on.
Just to add on to that, it's actually a funny anecdote. I remember when I started here 8 years ago, I had a meeting with MetroPlus, and I said, you know, in primary care, this goes back to the number of patients we have in primary care today and why that's a good thing. Generally speaking, what percentage of patients, if they don't have a primary care doctor when they're enrolling in MetroPlus, do you refer into H&H for primary care? And they just reflexively said 0%. And I said, well, hold the phone. We're partners, and you're part of H&H. And they're like, no, we refer nobody because you have no access. And they were entirely right. Our access, our third next available, was through the roof. So that was one of the first things I did when I came here was fixed access. We hired more doctors. We went to partial open access. We went to time release slots. We cut our wait times down by 50% in the first year or two. That's how we were able to both start the NYC Care program, but also then we went back to MetroPlus and said, it is a new day. We have access today that we didn't have a year ago. So then they started to refer the vast majority of new enrollees into primary care, and that's been something we've sought to continue with them. So just to make the point, I think this number, as you're saying, should be as high as it possibly can be. It's progress that's been made, and just as a funny anecdote to remember again, it's progress from where it started. Yeah.
No, thank you for sharing that, and thank you for making the improvements. I'm just wondering, in all these dashboard numbers, all of the targets are optically very close to where we are, and so I'm wondering, I know they can be improved, but why don't we just set them at where they should be, and then work towards it, as opposed to doing this sort of what feels like a little bit of optical game.
Yeah, I mean, great points. I mean, I think we should probably ask
Just sort of rhetorical.
in this one
Yeah.
on MetroPlus, it would be good to have a conversation with MetroPlus as to who are the 38%, where does that 38% spend falls and what is reasonable to increase and so on. Because I know that number has been
Yeah.
below 50 since,
It's been
for
hard.
many years,
Yeah,
right?
yeah.
And I just don't remember exactly the different reasons as to why that's the case, but it would be good to know how they think about that.
Yeah. Because I mean, this is a reasonable point, what you said, right? Access to getting a. So then you solve that issue, but then what's the next 5 issues?
Exactly.
To solve those next
But-
5.
Right.
Right.
They just can't, but they can't force people to.
Well, of course,
right,
of
do that.
course,
So,
of course.
I think the increase in primary care visits, those are all things that should be trending towards like improving access. It's been a question for a while. I mean, admittedly, like why can't that number be higher? But it's a little bit like the market speaks for itself, right? So.
And Frida, I would just add, I think, part of it is making MetroPlus more competitive throughout
Yeah.
the city is you actually, as they expand the network, they bring more individuals in.
Right.
And so seeing our percentage go down is not necessarily bad if it's attracting patients and maybe they come to us for some of their care, but,
Right.
they're growing overall. Because one important thing to note is that their actual risk surplus went up by 2% during this quarter.
Yeah, I was gonna
We
ask
actually
about
benefited
Which
from
went
that.
to us.
Yeah.
And, that's not part of the 38%, but it sort of is a benefit to us of them managing care well, of them bringing in additional
think that's
people
really
to
important,
improve the risk
yeah.
pool. And so this metric kind of only tells part of the story also.
Yeah.
And so it's not just about getting this number up, though. We'd like to if we can.
The other, sort of related but not exactly responsive piece, right, is the number of time and work that they're doing to get city employees on their gold plan, including H&H employees, right? And it's not going to be a perfect correlation. As soon as you have an H&H employee, they're going to get all of their care at H&H, though we very much would like them to. But I think if you're, to your point about how are we approaching a problem, from a variety of ways, that's another thing that, again, it's not direct, but I think will ideally be helpful as we go forward.
It's actually sorry, I'm still thinking about your question. It is an interesting one because in a way you'd almost think like from my primary care point of view, the number of patients they're receiving care in H&H that have MetroPlus is sort of the metric that would be meaningful to me personally. Because if that number is going up, even if they enroll 1 million more patients and we get a risk surplus from that, this number doesn't really capture as precisely the former. The dynamic, because I'm still like today, for example, we are continuing to figure out how we want to time release appointments so that MetroPlus patients can get in. Actually, we're time releasing our appointments now 10 days. So you call when you're a new MetroPlus patient, you'll get an appointment in 10 days or at exactly the 10-day point. But I'd want to understand the impact of that, which ultimately is the number of patients in our primary care system that have MetroPlus.
Right, and so
Right.
then it's like there's the financial piece and the patient
Right.
access.
It's two different pieces.
Yeah,
Right.
yeah.
And this sort of tries to blend them together, but.
Yeah, I mean, I wonder if we should also look at whether that target, or whether that dashboard metric might be better served as absolute dollar, not dollars, absolute
Patients.
patients, right?
Yeah.
Numbers of patients as opposed to percentage.
Makes
To that
sense.
great point. So.
Yeah.
Talk about.
Okay.
Yeah, I mean, I don't know, I can think of many different ways of thinking about this. One could be to bring up a conversation about what are the benefits of MetroPlus in general for a system, having a subsidiary, that sort of thing. Because I think that would cover like all these questions. And I'll coordinate to figure out what is the best way of doing it, whether it's through the committee or some other
Be good, like
educational session.
session, yeah, because there's all to it.
So that,
Okay. Another TED one. Okay, so now we're on negative trends, but again, things that we are working on, keeping our eyes on. One is the number of e-consults, and this one is very interesting, right? Because you can see the target is 95,000. You can see we're down to 78,000, but there's a partial or pretty compelling explanation for that, which is that Ted and his team, Dr. Hannah Jackson, Dr. Andrew Wallach, are really changing the model of e-consults to some extent to take it to the way that it was sort of envisioned to work. And so there's
Yep.
some transition. I don't know, Ted, what else?
Yeah, so basically, we expect this number to go down because what the system that we were going towards previous to this was to have every single consult for every specialty go through the eConsult platform, which sounds kind of like it has face validity, but the problem is a lot of the specialists, because we were overwhelming them with the number of e-consults, were just saying accept, 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 accept. So effectively, it wasn't serving a purpose if you accept 100% and don't respond to any of them. So it turns out we're not alone, that other systems had the same problem. So we joined a collaborative that's run by the AAMC nationally. They said the best practice for e-consults is to bifurcate. When you're placing the e-consult, you should say, I actually want to place the e-consult for a question. I want to see if James, with the growth on his hand and his hand x-ray, actually needs to see ortho. Making that up, hopefully. Feeling strong.
We'll find out.
Ruled that out. Or if it's if I want to place a direct referral, perhaps I don't need to go through the e-consult platform because I don't actually want a response back from the specialist. I just know the patient needs to be seen. So that's the direction we're going in now. So the number of e-consults goes down because some number of them are now direct referrals, which makes the system more efficient. It's less burden on the specialists. It actually gets higher quality responses back from the specialists and is matching the best practice that we get from the National Collaborative. Does that make sense?
So is that another target that's going to be revised?
Yeah.
question.
We were sort of talking about that. I think we've started now with 3 major areas, right?
Yeah.
And that's going to continue to roll out. So yeah, I think there's going to need to be a different way of capturing it, but I don't think that we're quite there yet in understanding what that will be.
Agree.
That will come. NYC Care, so this one is interesting. The number is down a bit, 130 from 134. Our target is 150. This is one of those where it's a good news, bad news, right? Number is down, but in large part that's because we saw an increase of 65 plus patients who became eligible for Medicaid when that policy change happened. We've talked about this here a little bit before. I think we at the same time are very mindful of the fact that, there may be some fear for people to continue enrolling in NYC Care. One of the big things we've done in response to that is to launch a pretty extensive advertising campaign. You may have seen it. It's Light the Way, and like the card is sort of this beautiful beacon. I'm happy to share those ads with you. We're really, really pleased with them. And actually, one of the metrics on that that's very interesting is we track we track NYC Care enrollment against our advertising efforts. And this one, since we launched Light the Way, it is significantly up. It's like a huge spike in the chart. So it's really, that's something that's exciting, and we will continue to do. And we think that's really important in terms of putting the marker down on who we are, particularly at this time.
Mm-hmm.
I wonder if this section is about access to care. I think the NYC Care one was a very good one, right, to demonstrate that. Is number of e-consults really a good metric for access to care?
So, I mean, this is ultimately a TED, but ultimately what you're trying to do is get people to specialty consults without them having to take another day off of work to go to another appointment. So to me, it really speaks to access.
Does it include televisit?
Includes any visit
Yeah.
with the specialist.
It's
But it's
specialist versus the form of visit.
Yeah. Well, this is just whether, regardless of the visit type, this is just going to see the specialist. These are predominantly in-person visits, although I think some of them might be televisits. But it pertains to access. I agree with Deb. It pertains to access because it not only represents your ability to get an answer for a specialty question quickly for your patient, but also the more e-consults we effectively do, the national data shows us that 1 out of every 5 current visits in the absence of e-consult may not be necessary. So that actually increases your overall access by 20% if you reach its real potential. So it has a very important impact on access. Yeah.
Another thing I just thought about, I have friends that are leaving corporate and going on their own personally and figuring out insurance, and because Marketplace is relatively expensive and potentially subsidies are going away, they're going to alternative forms, right? And so I forgot what it's called, DPT or something.
Direct primary care?
Yes, where they pay a membership fee and they just have a specialist. Let's say as a woman I need a GYN, right? So my GYN is my specialist primary, right? And I pay a monthly fee to be part of that network, and I have consultations with her. I'm not necessarily going into her until I have an annual. But the point is, wouldn't the e-consults number and structure be competing with that, or should be competitive with that in terms of our numbers? Like if I'm seeing more people going to DPT, shouldn't I also see more people going towards number of e-consults?
Good question. I mean, I think DPT you can almost compare to NYC Care in a way. It's almost like your way of accessing outpatient care. But somebody going into DPT probably wouldn't also be in our systems. They'd be leaving our system to go into that new scenario. But so I think to just draw an analogy here, like NYC Care is almost like universal access to outpatient insurance like or care that way, which is similar to DPT. It connects you to everything you need for outpatient care. You have your individualized fee scale, it's printed on your card, your doctor's name is on the card, and you get specialty access through eConsult. So we, just to say another word about NYC Care too, I think what Deb said is important. We think that the impact here of the decrease is in a good way because people are transitioning from NYC Care to Medicaid if they're 65 or above, which is the state policy. But we have a laser focus on NYC Care going forward to see if those numbers change, which could represent an impact of people changing the patterns with which they receive care due to fear and things like that. That's really important to us.
And as I often do, I will make a shameless plug for you all to follow our social media and get our press releases. There's a really nice series of the NYC Care ice cream truck. I don't know what you call it, but sort of a van that we've been sending out for people to provide information and to facilitate enrollment. And that's, a small thing, but it's part of a larger, as Ted says, laser focus on the issue.
Are you seeing most of the people in NYC Care being elderly people?
No, only a small segment are people that are 65 and above, and they're directionally shifting from NYC Care to Medicaid now. So if you think about it, I don't remember the exact numbers, but let's say if it's 5 or 10,000, something like that, of former NYC Care members were 65 or above, they are now maybe not all, but going in the direction of getting state Medicaid. So they're falling off of NYC Care because they're going on to state Medicaid. So that decrease because of that reason isn't a bad thing. It's a good thing for them to be receiving
They stay in our
Medicaid.
universe because we tend to get
Yes.
Medicaid.
Exactly.
medication.
So it will increase our Medicaid numbers and decrease our NYC Care numbers on the order of thousands.
And again, better for the patient, better for the system.
Yeah.
Better for us.
Exactly.
right?
Yep. Yep.
Okay, thank you.
These are the racial inequity measures, and we sort of present these less as positive, negative, but more, as information points for you. The percentage of equity lenses applied to PI projects with data, and this one I just think is so interesting. So our target is 100 for the FY Q4. Goodness gracious, FY25 Q4. You can see that that's 111. We've got a little bit of a lag in the data. So thus far, we only have 34 for Q1 of 26, but that will continue to catch up. And this, it's I think a really nice way to measure our commitment to equity, and the ongoing work of our system. This one we've spoken a lot about. This is percentage of new physician hires being underrepresented minorities. The problem with this one continues to be that unknown that you see at the bottom. We cannot force people to provide this information. Our hiring, may be done by our affiliates. So, it does not represent a lack of commitment to the issue. Anecdotally, we see and understand that this is working, changing, always improving. But, the data, we continue to work on ways to capture it.
Question?
Yeah.
How do you measure the performance, the one before that? The lens, what is the process?
So it's PI projects that have data to support a health equity focus, right? And so it's based on, it's quantifiable instead of qualitative. That's what I got, but we can come back and do a little bit of a deeper dive on that one.
I know that
Unless
As to
any,
what the framework
unless
is,
any
like,
of my colleagues.
What the framework is for choosing, for being considered. I was just curious.
what I can tell you is in quality assurance performance improvement meetings, we discuss PI projects, and then you can tell whether the project had sliced the data a certain way. And then there's conversations about like, okay, are all groups getting the same type of care or the same benefit
So it's an
from a
equity
quality
question.
improvement?
It's an equity question during the process.
It's the way the data is sliced and looked at. Like, for example, let's say language is important
For Friday.
in access to care of some sort. Then do you see a difference in the outcome by language? And I think they're just counting those, right?
I think that's right.
Yeah.
And we had a very interesting PI presentation on Friday from Gotham about stratifying the data by language. There's a very clear equity gap, and that they were able to actually use that data to drive the quality improvement that they had.
We can come back with more on that one also.
Can I ask a very quick
Of
question?
course.
Just the last slide was about new hires. What's the current population, like women, men? Is it reflective? Is it 40-something?
I think that's, yeah, I don't want to quote wrong numbers to you, but that is my understanding, and we
Okay.
can get you that pretty quickly.
Next time we do the presentation, can you do a slide where what is the
Yep.
current status of all of these?
You got it.
A follow-up to that?
Sure,
Sorry, now
of
I'm
course.
stimulating my questions. Do you have pipeline data for like your residency programs?
Yeah, we can try to do
That
that,
would
but
be-
it's the
that would be
same,
helpful to
but
know.
just to be clear, it's the same problem, right? In terms of capturing the data, right? People aren't required to submit it.
No, that's fine. I understand.
yeah.
I understand that, but I'm curious about how H&H is
Yeah.
able to sustain their workforce by like keeping
Yeah.
the good people.
So,
you know.
I will say more qualitative, less quantitative. Are you familiar with our Mosaic program? Which
I
is a
actually
program,
have.
it's a program specifically for building that pipeline down to medical students or even
Yes, yes.
junior to that, specifically to address underrepresented minorities. So that's a one. But it is an important program, and we've been able to make some nice strides on that one. Okay, and then this is occupancy data. It's about the same, 74%, 74.3 from 74.9. You can see a little bit of a drop specifically for med-surg and ICU, but these are all very kind of, industry baseline numbers. I think this metric started during COVID when we were at, 99, 100, 102, and we were tracking for sort of different reasons. So big numbers are good here, but you don't want them to be too high either. And then that's the sort of pictorial representation. And that's in your slide. And then the last is just a glossary for some of the terms, and you've seen that.
Deborah, how often do we revisit the metrics? Like, is there a set schedule, or is it done on an as-needed
I
basis?
mean, a lot of times it comes from these conversations, and then on a quarterly basis, we will look at them. But that's, your feedback is super important here.
It goes basically like internally
Yeah.
discussions, they get presented here, we provide feedback, and then
Right, and then sometimes something will come up, for example, the e-consult, right? So that's an internal change, and we're seeing that sort of shift the way the metric is captured, responded to. And so that, as Dr. Pecan says, that will start us internally, and also kind of married to your feedback.
And you guys have like a much bigger
Yes.
dashboard that the leadership
Yes.
team is tracking.
And shout out to, I want to say, Hillary Jalon, the DNA team, Mydell De La Cruz on my team who's taken this over. They have,
But
The
these
tables upon
are
tables.
included in your dashboard.
Yeah.
We sort of have, the committee has kind of had the ones pulled out that are most relevant.
The one thing I would say, and I like Trisha's addition too, is that in some places where the number lacks context, like it's hard for us to know, is 65 good or
Right.
Look, it would be helpful to have benchmarks if they're available. I don't think we should do any original research on it, but if benchmarks on that type of thing are available, it would be helpful for us to put it in context.
Okay.
I was gonna comment that on the e-consult one.
Yeah.
Like, to me, what I understood was, the issue is, can you get access to a specialist, and was that access necessary? I don't know if there are ways of looking at metrics that capture that concept where, I don't know if it's maybe because we just had an audit meeting, but there's a way of going through like a chart review or something that says,
Yeah.
for how many cases did we get the person on time, let's say within a month or 2 months or whatever the benchmark is? And then
Yeah.
how many of them were actually necessary?
Right, right.
Like there has to be, somebody must have thought of that, like
Yeah.
something like that.
So great question. People are thinking about that, and the good news about that is because we're part of the National AAMC Collaborative, we are talking that through with them, and we'll be able to, leverage the thoughts of others too. And part of the complexity is actually goes to Frida's point. We have on our end all of these like more precise KPIs, like did you get your care if you have a positive fit test within 30 days for colonoscopy, or if you're BI-RADS 0 in your mammogram. So we have all of these different sort of metrics that we follow. It's the challenge is rolling them all up into one sort of grand metric that still, to your point, has meaning. And that's where we're continuing to think about it. There's a couple of options. I mean, I don't know if we'd want to use this one, but for example, we can start to look at the percent of visits that are avoided because of an effective, high-quality e-consult with information given back to the primary care doctor. So that's the number I said nationally has been around 20%. The reason that's a little bit not a perfect metric is over time you don't necessarily expect that to go up or down too much. You just want to reach the level. But we're thinking about it, long-winded way of saying we have a variety of KPIs we look at, and we're just thinking with some of that national input about the best way to try to conceptualize it in a finite measure or two.
Tricia, you were gonna.
Yeah, just a last thing, because of what was said about defunding nurses as not a real profession. I know we're talking here about physicians,
Right.
but I don't know if you have any
So-
dashboards or
Yeah.
metrics around the nurses and how this might affect.
Yeah, and I mean, it's right. It's the issue of their.
I know
For
that's
those
the
of you,
talk of the day.
for those of you who are kind of not familiar to this, whether nurses are identified as professionals, which of course they are, who would be eligible for some student loans and from federal financial support. Obviously, we are in complete favor of anything that is going to support our nurses. But yeah, we can kind of bring back some numbers there as well.
Okay, anything else? Okay, is there any old or new business to come before the committee? Hearing none, meeting is adjourned. Thank you.
Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed.